Hello, this is Abnormal Psychology, and we are going to talk about obsessive compulsive and related disorders. This is part one. So, obsessive compulsive disorder was until 2013 located in the anxiety disorders because its major symptom is anxiety. But it has enough differences that it can be thought of as deserving a section of its own and to include a few other disorders. We're going to talk about obsessive compulsive disorder, body dysmorphic disorder, hoarding disorder, and trichotillomania. Okay? We will not talk about excoriation disorder, which is skin picking, compulsive skin picking. Okay? So I have a couple of videos in your PowerPoint that relate to obsessive compulsive disorder. One is a young woman who is a national spokesperson for obsessive compulsive disorder, and she shows you how she goes about her day by opening doors with her feet and those sorts of things, and cleanliness and the desire to not have germs near her. And then the story, a brief one, about 9 minutes, about Howie Mandel, who has an ongoing significant case of obsessive compulsive disorder. He's a germaphobe. And we're going to talk about different subcategories, subtypes of obsessive compulsive disorder. So the first thing is that obsessive compulsive disorder has obsessions. And they always have obsessions, but there's a small group that don't have compulsions. They are called the O-only obsessive compulsive disorder clients. But most, overwhelmingly, have both obsessions and compulsions. Obsessions are recurrent and persistent, intrusive thoughts, urges, images, cause a lot of distress and anxiety. The client will try to keep these away. Oh my goodness, that bump they hit, that thing in the road. Well, I don't want to. What was that? I don't know. And they get out, and they want to go behind the car, they look for it. So that's the obsessions. What are the compulsions? Well, repetitive behavior that seems to, and for a very brief period of time, reduce the anxiety. So if you're a germaphobe, washing your hands will, the moment after you finish washing your hands or while you're washing your hands, will reduce your anxiety. And of course, whatever you do right after an obsessional thought occurs that reduces your anxiety, you're going to do that again because the anxiety is very high in these folks. Okay? So the compulsions are repetitive behaviors that they feel driven to perform, that they have an awfully difficult time not doing. In fact, they develop very particular rules about how those things have to be done. Washing our hands in a particular way for a particular length of time, touching the faucet in a particular way a certain number of times. It gets very rigid. And they are behaviors and sometimes mental activities not connected in any realistic way to what they're designed to neutralize or prevent. And so they're usually very excessive, very time-consuming, these compulsions. More than an hour a day. Significant distress, impairment. There are people who, with severe forms of OCD, who have developed agoraphobia. Yeah. Okay. So some people with this disorder, and this is usually the case, that they have some kind of insight, good to fair insight. They know that what their beliefs are, and they know that what they're doing are probably not rational. And these are folks who really don't like divulging that. They may come in to see you as a therapist and talk to you about depression, but not talk to you about obsessive compulsive disorder. They won't talk about the obsessions. They don't want to talk about the compulsions. So you need to always ask about this anytime someone comes in with any anxiety or any depression. About 2/3 of people with this disorder, if it's moderate to severe, and within about 6 months develop some level of depression. So now you've got two disorders. If a person has poor insight, then they will actually believe that what their intrusive thoughts are actually true, and so it will justify the compulsions. And if they have no insight, if they're delusional, maybe even in denial about the irrationality, then they're convinced that their beliefs are true. They're convinced that they have to do these things. It makes treatment incredibly more difficult, sometimes really almost impossible. I hate saying that, but it's essentially true. So about 1.2% of the population has a lifetime prevalence, slightly higher than females, but males are more commonly affected in childhood and females more likely in 20s. There's an overlap there, so that's not a significant statistic. But let's say age is usually teenage years to early adulthood. If you're 30 and you haven't had obsessive compulsive disorder, it's probably not going to erupt. But you will tend to see some things in childhood. We'll talk about that soon enough. The real devastating statistic for this disorder is that less than 40% receive treatment for obsessive compulsive disorder. Some of that comes from the poor to absent insight. Some of that comes from embarrassment and not divulging it to therapists, but some of it comes from just not wanting therapy at all, and so on. You know, like all disorders in the Middle Ages, people were thought to be possessed who had this disorder if it was significant. They thought it was cleansing of guilt if they were a germaphobe with OCD in the 17th century. In the 18th century, they started thinking it might be medical. And then in the 20th century, we started treating it with medical interventions and behavioral techniques. And that's the way it is for virtually all disorders. So what are the defining features of obsessions? Glad you asked. The first one is that they're intrusive. They don't want to have them. They don't want to be thinking that. They're unacceptable. So I can't stand this distress when I think about this. It's not good to have this thought. They resist it. I don't want to think this. I don't want to think this. It's uncontrollable. They cannot not think this. They can't stop it. It's ego dystonic. It's not consistent with a healthy ego. This can't be who I am. How could I be thinking this? I'm not like that. Well, people with OCD tend to be people who are more depressed on average than others. They have higher standards of morality and conduct. They tend to be a bit perfectionistic. They often don't see the difference between thoughts and behaviors. They believe they should have perfect control over their thoughts and their behaviors. Yeah, you often see that collection. You know, they may be concerned that they're going to act out on some of these intrusive thoughts, but that usually doesn't happen. That almost never happens. It doesn't lead to violence or immoral activities of a sexual kind. No. What are some things other than depression that go with this? What are the comorbid conditions? Well, schizophrenia is one. In fact, schizophrenia is sometimes mistaken for this because it's sometimes, at least initially, hard to separate delusions and obsessions in severe cases from schizophrenia. Well, Tourette syndrome, that's another one. Facial tics, tremors. Yeah. So there are subtypes. Fear of contamination subtype, pathological doubt, aggression or sexuality, precision symmetry, religious scrupulosity, and superstitious or idiosyncratic as well. Okay? Yeah, I know you're not going to remember those, so we'll go through each one, okay? The first one is the contamination subtype. That's where you fear germs, getting ill, having other people get ill, and so you will have immediate fears of things like doorknobs, public rooms, restaurants, trash, sneezing or coughing people, shoes, sexual activity, poisoning oneself or others. So these are folks who are cleaners and hand washers, and they shower and do laundry constantly. They'll enormous time consumption, enormous. Okay. Then there's the pathological doubt group. These are people who may have issues of safety where they worry about having turned off the stove, or a burglar or disaster coming. They may have performance doubts. They forget to sign a check, forget to, uh, you know, uh, they fear embarrassment. They forget to send an email. And then there's a driving subtype where they think they may have hit someone. Now, the associated compulsions for all this are obvious: repeatedly checking, reassurance seeking, enormous time consumption. Then the aggression subtype, and this is images that images and impulses that you're going to harm someone. That's the obsession, and so you're gonna or harm yourself. So you go about things like checking underneath the car if you hit a pothole, and making sure you're away from a window or an edge where you're not going to throw yourself over, that sort of thing. Okay. In a minute, part 2.